Okay, this is lecture 4 on the Essential Emergency Airway Care course. This will be on direct laryngoscopy. Just to review, the indications for emergency airway or for intubation will be, the patient has to be appropriate to intubate. You'll need to protect the airway. You can't provide oxygenation any other way, or the patient has an anticipated difficult course that sort of mandates intubation. The tube, just to briefly go over the equipment, right? We have Mack and Miller blades, basically curved and straight blades. There are several types of each. And for generally, a 3 is good for smaller or medium-sized patients, and a 4 is good for it. We're going to teach almost totally Mack blade technique here. And then for tube size, an 8.0 is fine to put an 8.0 in almost anyone, but a 7.5, sometimes people have quite a bit easier time passing. A 7.5 is fine on almost any patient. And then, of course, any tube is better than no tube, so if you're having trouble, you can always go down to a smaller size. This is for adults, of course. We'll go over our airway algorithm again, and we'll sort of focus on our plan A, plan B, which tend to be the laryngoscopy portions of it. The most frequent plan is you use direct laryngoscopy as your plan A. And this algorithm that we have here, sort of just to remind everybody, reminds some essential sort of best practice techniques about pre-oxygenating the patient, apneic oxygen, optimizing their position, using a checklist, doing a formal airway assessment, and we're encouraging people to use a bougie or a stylet every time. Then, of course, reminds people that after a failed attempt or an unsuccessful attempt, the patient should be re-oxygenated. Usually that requires or should include 2 persons using the bag valve mask and an OPA, NPA if needed. And then if you take another look or another attempt after bagging the patient up and sort of thinking about it, make sure you're changing something. Figure out what you're going to do different between your first and second and maybe even third laryngoscopy attempt. That's going to maximize your chances for success. And of course, if it's your second attempt, make sure you're using a bougie. Make sure you're using all your tricks to maximize your chance for success. Remember, in your first shot at laryngoscopy is most likely to be the best one. Every attempt increases your chance at adverse events, creates some edema, some bleeding, some other things. So you want that first attempt to be as maximized for success as possible. And one of the most important ways to do that is to really go back on lectures 1 and 2 to talk about preparing the team and oxygenation. Remember, you have maybe up to 10 minutes of apnea, and really in the emergency room, you're intubating people who need to be intubated. We're not intubating elective cases. So we need to make sure to get them intubated as effectively as possible and with as little hypoxia as possible. So understand this graph that you don't have a lot of time before they get hypoxic, but you can increase your time by pre-oxygenating them well, by cramming up their PaO2 as high as possible beforehand, using apneic oxygenation, some other tricks. So again, just to remind people, look at lecture 2 for a more detailed thing, but every patient should have a nasal cannula on as high as topical. The non-hypoxic patients are fine with a non-rebreather mask on top of that nasal cannula. But if they're hypoxic, they also need a nasal cannula, and probably you can use a bag valve mask as long as it's got a PEEP valve attached, the end-tidal CO2 thing, and you're maintaining a good mask seal on top of that nasal cannula. We're not going to talk about non-invasive ventilation before, or delayed sequence intubation, or rapid sequence airway. So sort of advanced topics. We may talk about those in another lecture. Apneic oxygenation, just to review, of course, we prepared our patient with a nasal cannula. We have a rebreather or a bag valve mask with a PEEP on top of it. We've tested our end-tidal CO2 by warming it up and checking, make sure everybody knows how that's working. And our O2 sat is placed on a place that's not the arm with the blood pressure cuff. During the apneic period, after we've given our sedative and paralytic, we're giving a jaw thrust, making sure they have an open airway with an NPA or that laryngoscope. We'll remove the rebreather, use a tight mask seal with the bag valve mask to make sure they're breathing with that. And then during the intubation period, we're not taking off the nasal cannula. We're leaving it on and making sure that we have some way to keep an open airway. We're positioning them correctly. We've gone over that before. We have to ramp them if needed. Remember, ear to sternal notch level, no matter how obese they are. If for some reason we can't ramp them up, we can move the whole bed, and our face is parallel to ceiling, and our bed is at the correct height, at about the xiphoid. So just a reminder, some things that are frequently forgotten: an end-tidal CO2 detector that's already placed on the bag and the mask and is warmed up, and a PEEP valve as well on the BVM. A nasal cannula placed under the mask or the bag valve mask. The SAT probe is checked, and we're not hyperventilating any of our patients. Remember, we'll do a formal airway assessment. We're really trying to encourage an out loud formal airway assessment and talk about why each of these people are going to be difficult to intubate. So remember, we're teaching Lemon, which will help you maybe predict the difference between an anticipated difficult airway, which is every ED airway, to an anticipated very difficult airway, which maybe RSI won't be appropriate in some situations. So we're looking externally for blood, facial trauma, all that stuff. We're evaluating the 3-3-2 rule, right? Which means 3, and it's a general idea. The patient can open their mouth, the patient has a jaw of normal size, and the patient has a neck of normal size. So it's 3 of the patient's own fingers in their mouth, 3 of the patient's own fingers under their jaw, and 3 of their own finger above the thyroid to the hyoid. And the Malin potty, it has some usefulness, but the patients are usually flat on their back in the ED, so a little less useful for us downstairs. And then obstruction, right? If you're having difficulty ventilating the patient because of an obstruction, you're going to have difficulty intubating the patient. And then difficulty moving the neck can make things a little bit more difficult, or a lot more difficult. Holding the laryngoscope, of course, we're going to hold it in our left hand. We're going to hold it as near the bottom here of the blade as possible, and we're going to tuck our elbows in next to our arm. These are sort of some ergonomics that can really make a difference. And so you see people hold it up a little higher here. That makes you work a lot harder on your wrist, gives you a little less force and a lot less control. And the same thing here. This tires your shoulder and gives you less control. So tuck your arm in, choke up on the blade, you have a lot better success. So of course, everyone should know this anatomy, and it's sort of less useful from this angle, but it's somewhat helpful. But you really need to know it from this angle. So it gets confusing. It's dark in that hole. So start off with what you know. As you're going down, make sure you're identifying the teeth, the anterior tongue, posterior tongue. You can usually spot this. It makes things familiar again, hard palate, soft palate. Once you get down a little deeper, the epiglottis and the cords, these things get a little darker and further away down there. But you should be able to identify these as well. So remember, 4 steps. We've already sort of gone over how to prepare the patient, right? We've oxygenated them, we've optimized them, and we've positioned them and we've identified already our key anatomy. There's some lips there. Then we visualized that we've opened the mouth, we visualized the anterior tongue, we visualized the anterior pharynx, we've swept the tongue to the right side of the body. We're looking a little deeper into the posterior pharynx, we suction if we need to, and then we visualize the epiglottis. So that's the key. This step number 2 of visualizing the epiglottis is probably the hardest part. If you're having trouble visualizing the epiglottis, it usually means you need to move the head. Okay, so once you've visualized the epiglottis, which is sort of the first step of using the laryngoscope, then by moving the head and doing things, then you're next going to visualize the glottis. So we visualize the epiglottis. We're ready to, if we have trouble again getting that glottis, the epiglottis visualized, it's usually worthwhile to move the patient's whole head. That's a positioning problem. Visualizing the glottis, we sort of insert it a little lower. We can visualize the cords, tuck it into the vallecula, and that's the deal. You want to optimize it with some bimanual laryngeal manipulation. And then once you can see good, you're not done. You still have to pass the tube, which is harder than it seems. So you try to keep your eye on the glottis. Ask for the bougie. Hopefully you have a great assistant who hands it to you. And then insert it horizontally. Again, this is something I can just talk about. Really try to watch Dr. Scott Weingard's talk on it. It's a nice 15-minute talk, far better with video, also far better than what you'll get with me just going over it. But it's if there's one video to see on laryngoscopy, that's probably it. Using a bougie, very similar. You've prepared the patient. You find the epiglottis with the laryngoscope. You don't have to get quite as good a view, just a little hint of that posterior arytenoid cartilages, and then ask for the bougie, keep your eye on there, insert the tip onto the mouth, pass it. Oftentimes you can feel a click against the rings, although it's not particularly sensitive or specific, and then you can feel hold up too as you gently pass it through and it doesn't go all the way down through the patient's esophagus. Hopefully it's in the trachea and stops in the carina. You'll want to leave the laryngoscope in place and then railroad the bougie. railroad the ET tube over the bougie. Oftentimes the endotracheal tube will get hung up on the retinal cartridges. That's why you want to watch it. You want to pull it back a little bit like this and rotate counterclockwise. And then remove it and confirm. Again, there's 2 fantastic videos on some awesome tricks on how to use the bougie. Also, they give you a great feeling of the anatomy down there that most of us don't get to see. And I highly recommend these 2 videos as well. So if we're going to use a stylet, it's strongly recommended we use a straight to cuff style, and which the stylet needs to look like this. It's straight until it hits the cuff, and then it's bent 25 to 35 degrees. Make sure that the cuff doesn't stick out past the end of the bougie. This happens. We see this a lot, and for some reason in pediatrics it tends to happen. That's sort of a dangerous practice. You want to make sure that that stylet doesn't come out back. And then a syringe should be attached to the end of that, and it's extra credit if you attach it full. The more lubrication you can use when you insert this stylet, the better as well. So external laryngeal manipulation, there's sort of 3 types of this. There's the bimanual, which I'll show you next, which is basically the provider holds the laryngoscope with the left hand and holds the neck or the thyroid with the right hand and moves it around until he has his perfect vision. Then there's burp, which is probably more classically taught, which is an assistant moves it automatically backward, rightward, upward, and with some pressure. And it's probably a little less effective than bimanual. It worsens the view 40% of the time, makes it better 60% of the time isn't the best. And then there's cricoid pressure, where it's just a little downward pressure on the cricoid ring. And that's actually inferior. That's more towards the feet than the thyroid cartilage. Here's a picture of how external laryngeal manipulation works. There's a nice video on the website. And then cricoid pressure, there's a lot of debate about it. The claim, of course, is that it decreases the risk of aspiration. There are some negatives to it. It is one more step in a complicated situation already. There's some evidence that it actually increases your risk of aspiration, or decreases the aspiration pressure at least. It can sometimes make ventilation more difficult. It can definitely distort the airway a little bit. And sometimes it's actually hard to get the tube past the thing. There's a lot of debate, your institution, and you should decide yourself if you want to use it. There's definitely a long history of using it. It's not something that I use routinely, or I generally try to discourage people from using it. But there are lots of very intelligent people who think it's a great idea. It should definitely be released. If the team leader or the intubating operator wants it released, if the patient does vomit, you have to release it. And then if you're having difficulty ventilating the patient with cricoid pressure on, or if someone's having difficulty seeing, you should take the cricoid pressure off, or at least discuss that beforehand with your team and your intubator. So verifying tube placement, the gold standard, of course, is continuous waveform capnography. In order for that to work, it has to be warmed up and tested before the tube goes in. So you need to do that during the bag valve mask portion of the device. Additionally, a continued oximetry is very, very helpful. Dropping oximetry should be a big red flag as the tube's in the wrong place. There's all sorts of things. The mist in the tubes, the color capnography, the initial pulse oximetry, and the esophageal. Those are all okay, but they don't really have the great reliability. Used in conjunction with things, they can help you, but by themselves are usually not enough. Unreliable, the epigastric sounds, the misting, and symmetrical breath sounds and chest x-ray are no good. Oftentimes a frequently misunderstood thing is you can see a respiratory rate on the ECG leads even if you're ventilating the patient's stomach. So that's definitely unreliable. You confirm after every time you move. You confirm if somehow the patient stops ventilating well. There's a whole doped mnemonic and a hypoxia mnemonic. And then a chest x-ray. It just confirms the depth but doesn't confirm whether it's in the esophagus or the trachea. Again, this is the whole algorithm. The most frequent way we run it is direct laryngoscopy first, video laryngoscopy second. That doesn't have to be the case. You're welcome to do it in the reverse order. And the registry data shows that it's not uncommon for direct laryngoscopy to rescue video laryngoscopy. Supraglottic airway at the end. Remember all of our best practice techniques. And then, whenever you're wheeled in a laryngoscope, you should know also how to use a supraglottic airway and perform a cricothyrotomy. So we have our short checklist here. I don't think we need to go over that again, but remember you want to do a good briefing here to have everyone be on the same plan. And then right before the drugs get pushed, after everyone thinks they're ready to go, just run through this checklist in a call and response manner as fast as possible. And I think you'll be good to go. I strongly recommend watching some of the additional videos. This one on how to do laryngoscopy is a fantastic thing. Even if you really consider yourself a laryngoscopy master, it really helps you communicate your thoughts to maybe your juniors or your other ones. I couldn't recommend it more. Of course, Richard Levitan's the master at all this stuff, and anything you can read by him is great. There's some other stuff here that I strongly recommend as well. Go down, you'll be able to scroll down and sort of click through most of these on the sharpends.org's webpage. Thank you very much.